السلام عليكم. لؤي الصوت كان عندكم في مشكلة.
So today we have 3 lectures, inshallah. First one is AV canal defect will be presented by Dr. Cath. The second is about Truncus Arteriosus by Dr. Fatima Al-Hijab. And we have a special presentation today by Dr. James Cox about contemporary interventional therapy for atrial fibrillation. We are also glad to have Dr. Rahim Abdullah as a guest consultant with us in this session, who's a consultant cardiac surgeon at King Faisal Specialty Hospital in Riyadh. So we'll start, inshallah, 5 minutes past 1. Dr. Suha, you can prepare your slides. Thank you.
Assalamu alaikum. Good afternoon, everyone. Today, inshallah, we're going to talk about atrioventricular septal defect.
Can you wait for a while because we have a problem with the recording?
Sure.
We'll let you know, inshallah.
سهاد تفضلي.
Assalamu alaikum. Good afternoon, everyone. Today, inshallah, we're going to talk about atrioventricular septal defect, which is also known by other names such as endocardial cushion defect, Af canal defect, or Canalis atrioventricularis communis. So this is our main points for today. And as introduction, the term of partial and complete Af canal defect was first introduced in 1956 by Wakai Edwards, and the first repair was achieved in 1954. Let's go quickly through the report numbers. So it's not a rare disease and accounts for around 5% of congenital heart disease, with gender distribution approximately equal. So Af canal defect is strongly associated with Down syndrome, as the complete form of AVSD is the most frequent type of congenital heart diseases associated with trisomy 21. And almost 70% of the children with complete AVSD display this aneuploidy. So what causes Af canal defect? It's a result from faulty development of the endocardial cushions and atrioventricular septum. So as a result, incomplete fusion of the superior and inferior endocardial cushions. Let's get a step back and talk about normal anatomy so we can understand what's significant in Af canal that makes the difference. Here is the cut section of the heart where we took out the atria and great arteries and look at it from above. So this is anterior, posterior, right, and left. So you can see that mitral valve, tricuspid valve, aortic valve, and pulmonary valve, which is anterior. And you can see a strong relationship between the mitral and aortic valve. So normally there is an aortomitral continuity and big fibrous continuity joining the anterior leaflet to the aortic root. And you can see that the mitral valve has two leaflets. I know this is quite easy, but this is very relevant when we talk about the Af canal. So the mitral valve has two leaflets, anterior and posterior. The anterior mitral leaflet has a large surface area that covers most of the orifice of mitral valve. And it's only attached to nearly 1/3 of the circumference of the annulus, while the posterior leaflet is quite shallow and attached to nearly 2/3 of the circumference. And you can see that the middle of the anterior mitral leaflet here towards the LVOT and aortic valve. On another hand, the tricuspid valve has 3 leaflets, anterior, posterior, and septal. One important fact here is that the aortic valve is wedged between the mitral and tricuspid annuli. This is another cut section in the heart. Here you can appreciate that the tricuspid valve and mitral valve are not on the same level. You can see here the septal attachment of the tricuspid valve, while the mitral is attached to the papillary muscle, not to the septum. And you can see that the tricuspid is more toward the apex than the mitral. This is a cut section. Here, roughly, you can see the distance between the mitral annulus and the apex is equal to the distance between the apex and the aortic annulus. Here we zoom in view. So now we're looking from the right side. We took out the free wall of the right atrium and right ventricle and Now we are looking at the atrial septum, ventricular septum, and in between is the tricuspid valve. So this is the coronary sinus and the famous triangle of Koch, which is bounded by the tendon of Todaro, septal attachment of the tricuspid valve, and the coronary sinus at the base. So the apex of this triangle has the AV node, and immediately in front of it has the membranous septum, where the bundle of His comes from the AV node to cross from the atrium to the ventricle. So what is atrioventricular septal defect? This is obviously atrial septal defect and ventricular septal defect. So you can get an ASD and VSD, and you call that complete AV canal. The VSD can close spontaneously, probably before birth, and then you get only ASD, and you call this partial AV canal. Rarely, ASD can close while leaving the VSD open, and actually quite rare you can get closure of both ASD and VSD, and still you call this AVSD. So what is it if it's not just an ASD and VSD? If I ask you a question, like if a patient has big secondum ASD and like big perimembranous VSD, and isolated cleft mitral, would you call this an AVSD? Actually not. So the AVSD is a big spectrum that's ranging from partial canal to complete canal, and the hallmark of the AV canal is the presence of common AV junction. This picture explains the same with this type in between, which is transitional, which have the restrictive type of VSD. Do you remember here we talked about this? So we have right AV junction normal and left AV junction, and these obviously two different AV junctions in comparison to this. Here, there is a primum ASD, there is a let VSD, so this central part of the heart, it's just empty. So this is a common AV junction guarded by common valve with different configuration of leaflets. This is a patient with AVSD looking from above. There is no separate mitral and tricuspid valve, and as we have common junction, there is no place for the aorta to get wedged in between. So the aorta is displaced or anteriorly, and it's unwedged. This is a picture from above, and we are looking at the common AV valve. This goes into the right ventricle, while this goes into the left ventricle. So the plane of interventricular septum will be below here, while the ASD above. So if this is this one, if this is leaflet that bridges from above the left side to the right side, this is the superior bridging leaflet. And this is the inferior bridging leaflet. Towards the wall of the left ventricle, this is the left mural. On the right side, this is the right anterior superior and right mural. So generally, this valve is composed of 5 leaflets. And let's take a cut section. Here, looking from the right side, we took out the atria and right ventricle, looking at the atrial septum and ventricular septum. So the defect here, if I put my finger here, I will go to the left atrium. So this is ASD. You see the leaflet of the AV valve, superior bridging and inferior bridging leaflet, and the defect below the valve, this is the VSD, which is L-let VSD, where part of the defect reaches the AV valve, and the ventricular septum here is looked like being scooped out. In some patients, the superior bridging leaflet gets attached to the inferior bridging leaflet, and both of them gets attached to the crest of the ventricular septum, which is below, toward the ventricle. So technically, there is no communication between the ventricles, no VSD, and you get this. Now, it's still a common AV junction, but now there are two separate orifices. Each orifice is going to separate ventricle, and this is called partial AVSD. So the features of complete and partial are similar. They both have common atrioventricular junction with a 5-leaflet valve that guards the common AV orifice and unwedged left ventricular outflow. And the ventricular septum is still scoped out regardless there is VSD or not. So now we are looking at the left AV valve. This is the normal mitral valve, and this is the left AV valve of AV canal. So we are looking here. So you can imagine the aortic is somewhere here. So let's assume this is the anterior mitral leaflet that has a cleft, and this joint leaflet is the anterior leaflet. It will be attached toward to more than 1/3 of the annulus, with mural leaflet only 1/5 or 1/6 of the annulus, and it will be pointing toward the septum here, not to the aorta. And the cords will be attached along the cleft, and we will call this zone of apposition between the left component of superior bridging leaflet and inferior bridging leaflet of the common AV valve. There is a Rastelli classification which based on the relationships of the anterior bridging leaflets to the crest of the ventricular septum or RV papillary muscle. So in type A, the anterior bridging leaflet is tightly tethered to the crest of the interventricular septum, which is the most common type in around 50 to 70%. Type B, which is the rare, the anterior bridging leaflet is not attached to the interventricular septum. It's attached to the anomalous RV papillary muscle and always associated with unbalanced AV canal. In type C, there will be a free-floating anterior leaflet attached to the anterior papillary muscle. This figure is showing the relation between the associated anomalies and the Rastelli classification. As you can see, in type C is mostly associated with tetralogy of Fallot, and the type A with subaortic stenosis or coarctation of aorta or both. So you remember when we talked about the normal anatomy and the inflow is roughly equal to the outflow, while in AV canal, the ventricular septum is scooped out and the aorta is displaced anteriorly and unwedged. So the inlet got much shorter while the outlet has become longer. And the LVOT in these patients is longer and narrower. And when we do angiography with echo, they imagine that as gauze neck appearance. Now, what about conduction? The AV node have the AV node and bundle of His passing through the membranous septum going towards the base of medial papillary. In patients with AVSD, this area is empty. So the conduction tissue cannot be like swim or floating. So there is still AV node and bundle of His, but it cannot be on the apex of the triangle of Koch. It has to be displaced posterior and inferior. So you will get something like that. And the bundle of His here has to go long way before start branching, because normally the main bundle of his would go for short distance before branching into right and left bundle. While in AFESD, the main bundle has to go a really long way along the crest of the septum before start branching into right and left bundle branch. Now, what if the common AV junction is not equally aligned over the crest of the septum? So if it is more toward one ventricle than the other, and more blood will go for one ventricle and less to the other, so this will cause hypoplastic ventricle, and this is the concept of unbalanced AVSD. Other thing that can happen with these patients is that one of the bridging leaflets gets attached to the mural leaflet, and this will divide the left AV into two orifices, which is a double orifice left AV valve. For the pathophysiology, in case of partial AVSD, the long-term complications that will develop due to right-sided volume overload and dilatation that will lead to arrhythmia and ventricular dysfunction and potential pulmonary vascular disease. With complete AVSD, there is left to right shunt, and this will lead to pulmonary overcirculation and congestive heart failure with irreversible pulmonary vascular disease that will develop very rapidly due to this large shunt. And up to 90% of untreated patients, they will develop pulmonary vascular disease by 1 year of age. The associated anomalies most common in partial AVSD is the secondum ASD and left SVC to coronary sinus. In case of complete AVSD, in type A usually is isolated defect and frequent in patients with Down syndrome. Type C will be with the TOF, Dorf, transposition great arteries, and heterotaxy syndromes. In case of combination of type C, complete AVSD with TOF, this is observed in Down syndrome, whereas the Dorf is a feature in patients with asplenia. This slide is showing the clinical characteristics of genetic disorders associated with AVSD. Also, other genetic disorders. This slide has the same. Coming to the clinical manifestation, the patients with partial AVSD are usually asymptomatic. Symptoms of dyspnea, easy fatigability, recurrent respiratory tract infection, or growth retardation may be present early if there is major mitral regurg or like left AV valve regurg. In patients with complete AVSD, tachypnea and failure to thrive occur much early, and almost all patients, they have the symptoms by 1 year of age. Physical examination may reveal undernourished and signs of congestive heart failure. So we will have hyperactive pericardium with systolic thrill, and this one is accentuated S2 narrowly spread and increased intensity in P2 with grade 3 to 4 holosystolic murmur. ECG may show left axis deviation. Almost all patients will have prolonged VR interval with atrial enlargement, and all cases will have right ventricular hypertrophy or right bundle branch block. Chest X-ray will show cardiomegaly and increased pulmonary vascular markings. Echo is the primary imaging technique for the diagnosis of AV canal, and internal cardiac crux is the most consistent imaging landmark. With apical four-chamber plane, this will clearly visualize the hallmark of the internal crux. And also the primum ASD, it will be seen as an absence of the lower interatrial septum. Other features by echo include deficiency of portion of the inlet ventricular septum and inferior displacement of the AV valves and attachment of a portion of the left AV valve to the septum. And the most common left AV valve abnormality is a cleft, and it's best visualized by the parasternal and subcostal short axis plane. In transitional type of partial AV canal, there will be aneurysmal replacement of a portion of the inlet ventricular septum as it's shown in the picture. For cardiac cath and angiography, it's rarely required for diagnosis. Just in older patients, it may be used for assessing the degree of pulmonary vascular obstructive disease or coronary artery disease. And left ventricular angiography may show the gauze neck deformation of the LVOT. Coming to the treatment, patients with incomplete AV or partial AV septal defect will present with signs and symptoms that's similar to those of secondum ASD. So, as such, they are rarely required medical therapy. In case of complete AVSD, medical therapy consists of aggressive anticongestive treatment for signs and symptoms of congestive heart failure. And the mainstay of medical therapy are furosemide for diuresis for the overloaded heart, digoxin as mild inotrope, and AC inhibitors for afterload reduction. Pulmonary artery banding is not now, it's not used frequently now in infants with the AV canal because the surgical risk of intracardiac repair are not significantly greater than the palliative procedure. And the indications for pulmonary artery banding may include patients with AVSD and associated complex cardiac anomalies. That is like necessitating an ultimate like TAN procedure or those with poor clinical condition precluding major cardiac surgery. So in case of partial AVSD, timing of the surgery is similar to ASD repair between age of 2 and 4, and incomplete, it should be taken in early duration between 3 to 6 months of age, and even earlier if the heart failure cannot be controlled, and such failure to thrive or intractable respiratory symptoms. So coming to the surgical treatment, which is achieved by different techniques. First is the single batch technique, the double batch technique, and the modified single batch technique, which is also known as Australian or NUN technique. So normally the setup started as usual by standard invasive monitoring and general anesthesia and median sternotomy with asymmetrical pericardiotomy. So that large batch of the pericardium can be like harvested and placed in glutaraldehyde. Standard cardiopulmonary bypass with distal ascending aortic cannula with bicaval venous cannula, and the patient can cold to 28 to 32 with anti-grade cardioplegia. Coming to the technique, regardless of which approach is selected, first elevate the common AV valve to its closed position by injecting cold isotonic sodium chloride solution into the ventricles to assess the valvular competence and structure. Then the central apposition of the superior bridging leaflet and inferior bridging leaflet is the area where the two leaflets meet at a point separating the left and right AV valves. So identify and mark these points with fine polypropylene sutures, as it's shown in the picture. For two-batch technique, fashion a batch into a crescent shape to match the dimensions of the ventricular septal defect, and secure this batch along the ventricular septal crest slightly on the rightward aspect and inferior to avoid the conduction system. Then septate the common AV valve into right and left valve along the line overlying the ventricular septal crest that defined by point of central opposition and hinge points at which the VSD meets the AV valve annulus beneath the superior and inferior bridging leaflet. And place interrupted horizontal matrix suture through the crest of the VSD patch and then the superior and inferior bridging leaflets. Then pass these same sutures through the edge of the autologous pericardial batch for closure of ASD and tie them so the pericardial batch is secured to the crest of the prosthetic ventricular septum. And we can say that the superior and inferior bridging leaflets it's somehow sandwiched between the two batches. For one batch technique, divide the superior and inferior bridging leaflet along a line separating them into right and left components. Then similar to the two batch repair, secure the batch to the crest of the ventricular septum, then resuspend the leaflets to the batch by passing interrupted sutures through cut edge of the left AV valve leaflet and the batch and the cut edge of the right AV valve and tie the suture. And whatever the technique is used, reassess the AV valves for adequate orifice size and competence by filling the ventricles with cold isotonic sodium chloride solution. Although earlier reports recommended that the cleft in the left AV valve not be closed and the valve be treated as tri-leaflet structure, most authors currently believe that closure of the cleft is important mechanism in preventing post-operative left AV valve regurgitation, as it's shown here. And this is important. An article published by Boga et al. Has identified that AV valve regurgitation at the conclusion of the surgery, also severe dysplasia of the left AV valve and failure to close the cleft of the left AV valve is an important risk factors for repeat the surgery. And according to Studer et al. And Stewart et al., significant post-operative left AV valve regurgitation is also risk factor for surgical and long-term mortality. There are special considerations that necessary for patients with AV canal and associated single papillary muscle to the left AV valve or double orifice valve. So do not completely close the cleft in the presence of a single papillary muscle to avoid causing left AV valve stenosis. And in double orifice valve, do not divide the bridging tissue to create a single opening in the valve. And the ASD is closed with an autologous pericardial batch. So the coronary sinus is placed in the left atrium to avoid the injury to the conduction system, as it's shown in the picture. For the modified single batch technique, I will share with you a short video.
ventricular septal defects, and you can see in all of them, the issue is at the center of the heart, where the atrial and ventricular septums are, and where the mitral and tricuspid valves come together. In complete atrial ventricular septal defect on the far left, there is a large hole in the center with one big common valve instead of separate mitral and tricuspid valves. As we move to the right, the intermediate and transitional septal defects have more completely formed mitral and tricuspid valves, and you can see in the partial canal there is no hole in the ventricular septum, but there is an atrial septal defect and a gap in the mitral valve. Today I'll be showing a repair of complete atrial ventricular septal defect. In this animation, you can see the right atrium, right ventricle, left atrium, and left ventricle. Shown is the large ventricular septal defect and large atrial septal defect. The arrows show the direction of blood flow from the left side of the heart to the right side. This causes increased volume and work for the right heart. The surgical repair of atrial ventricular septal defect involves closing the ventricular septal defect and the atrial septal defect, and then reconstructing the two valves. There are two main methods for repairing complete atrial ventricular septal defect. One is the double patch repair, which was illustrated in the last animation, and the second is the modified single patch, which will be shown in the upcoming video. In the modified single patch, there is one patch that closes both the atrial septal defect and the ventricular septal defect, and the edges of the valve are brought down to the top part of the ventricular septum. This is a 4-month-old with Down syndrome and complete atrial ventricular septal defect. We are already on the heart-lung machine and the heart is stopped. We are examining the common valve, first the inferior part and now the superior, what's called the bridging leaflet. Here we are testing the valve and floating the leaflets. You can appreciate right now there is one big valve instead of separate mitral and tricuspid valves. The first step will be figuring out where the middle will be, where the new septum that we will create will go. Now we are putting in stitches for where the middle will be. This shows placing each of the stitches, taking bites in the ventricular septum, going through where the midpoint of the common valve is where it will be partitioned, and then going through the patch. Again, this partitions the common valve into two valves and at the same time will close the ventricular septal defect. The patch now has been pushed down in place and we will tie all the sutures. The patch is made of the baby's own pericardium, which is the lining around the heart. Now we are examining the mitral valve and will close the gap that you can see near the patch. This is also called the mitral cleft. This gap is closed with fine suture. We are testing the valve again to make sure that it doesn't leak, and here you can see the row of sutures closing the cleft. Now we are repairing the tricuspid valve in a similar manner. The last step of the operation is to close the atrial septal defect utilizing the same patch. Here the operation is finished.
So regarding this technique, Wilcox et al. In 1997, they operated on 12 patients and reported good surgical results. In 1999, Nicholson et al. Reported from Australia 47 patients with good outcome. In 2007, none reported 128 patients in whom the modified single batch technique was applied in all cases, and he reported 30-day mortality rate of 1.6%, 2.3% incidence of reoperation on the mitral valve, with no reoperation for residual VSD and no incidence of LVOT. In 2007, Becker et al. Compared 26 patients with modified single batch technique with 29 patients with standard double batch technique, and they found no significant differences in mortality, residual VSD, degree of mitral or tricuspid insufficiency, reoperation on the mitral valve, or LVOT. This is a graphical abstract of a study titled as Complete Atrioventricular Septal Defect Repair in Australia, results over 25 years. And it's evaluated whether the long-term outcomes of modified single batch repair of complete AVSD are equivalent to double batch repair with respect to survival and risk of reoperation for left AV valve regurgitation or left outflow tract obstruction. And they found the survival are similar following either technique, and there is no increased risk of reoperation with modified technique. Coming to the complications, in those children after 6 months, there is a risk of post-operative pulmonary hypertensive crisis. Also significant of AV valve regurgitation in 10 to 15%, reoperation in 10%, also permanent complete AV block in 1%, and right bundle branch block reported in 20%. Down syndrome patients may have lower mortality, lower reoperation rate with less preoperative valve regurgitation. This is another study done in our center, which is titled as Outcomes of Surgical Repair of Complete AV Canal Defect in Patients Younger than 2 years of age. They found like 70% of patients were Down syndrome, and there was a significant association between preoperative pulmonary hypertension and the development of pulmonary hypertension in the postoperative period. Also, the presence of preoperative and postoperative AV valve regurg was common, but did not significantly affect patient survival. Also, infection was the most common complication, then arrhythmia with around 14%. This is the end of my lecture. Thank you for listening. I hope it was clear.
Thank you so much. Nice presentation.
Thank you. So I'm not sure Dr. Ibrahim is with us.
Assalamu alaikum. Yes, that was an excellent presentation. Very well, very comprehensively captured the diagnosis and the morphology, anatomy, and some of the surgical considerations in the repair. Does anyone have, I know this is a session with the fellows and the residents, and we want to keep it, I'd like to keep it more so as an opportunity for questions that folks may have. And whatever I can add from my own experience, as well as perhaps others as well. Were you able to hear me?
Yeah,
yes,
we can
Doctor,
hear.
we hear you. Yes.
Okay. Okay.
So anyone has a question for Suha or Dr. Ibrahim?
So maybe I'll add a few things. This is a question that we would get on the boards, and Suha also touched upon this. What do we think is the most common complication after an AV canal repair or AV septal defect repair? And anyone can freely answer.
Yes, Dr. Abdullah, if you allow me. So in short term, would say conduction abnormality and pulmonary hypertensive crisis, and in long term AV valve regurgitation.
So, sorry, I got a call in the middle of this. Yes, I heard you said conduction system, and you mentioned pulmonary hypertension. Yes, those are well-known issues and complications. But typically, what will the things, or maybe I should rephrase the question. What is the most common reason for a reoperation?
AV valve regurgitation.
Yes, correct. So, and which one?
Left side.
Left side, correct. And one of the things that was found, and I don't have the paper in front of me, but one of the things that was found when they reviewed the various techniques in Boston Children's, they found that the single patch technique, not the modified single patch technique, but the single patch technique where the superior and inferior bridging leaflets were divided and a patch was like almost like a circular type patch was sewn that had a VSD component as well as an atrial component. Interestingly, they found that, and one of the surgeons was using that technique out of the I think 4 or 5 surgeons at Boston Children's, and they found that technique had the least recurrence or least amount of AV valve regurgitation in follow-up, in long-term follow-up. And when they went back to look at those patients, they looked at I believe they looked at the dimension, the anterior posterior dimension of the where the crest of the septum would be. The anterior posterior dimension was less, consistently less in the single patch technique patients as opposed to the 2-patch technique patients. Why that was the case, I'm not sure, but the surgeon was very particular, and this was actually Dr. John Meyer. He would make the anterior posterior dimension a little bit less, and it was felt that was bringing the annulus down for the left-sided valve and contributed to less regurgitation. So I think that's a consideration when you're doing this repair, even if you're doing a 2-patch repair or you're doing a single patch repair where there is a VSD component. Keeping that anterior posterior dimension slightly smaller than the actual dimension may help with that in the longer term. You may not have so much of an ability to do that with the modified single patch technique, where the superior and inferior bridging leaflets are as Saha had shown, they're actually placed right on top of the crest of the septum. So you're essentially obliterating of VSD, but some surgeons, even back in the Boston group, what they did after they discovered this anterior posterior dimension thing, even with a single modified technique, they would put a Dacron strip to kind of bring that dimension. So the Dacron strip would be on top or on the atrial side of the AV valves to help bring that dimension down. I'm sorry, it's hard for me to explain with words unless you're actually visualizing this, but hopefully you have some sense of what I'm trying to say.
Thank you.
Any other questions or comments or thoughts? Now,
I believe no other questions.
Thank you, Dr. Ibrahim, and thank you all for listening.
you're welcome. Excellent presentation. Thank you so much.
So we'll have a break for 5 minutes and then we'll join again for the second lecture. Dr. Fatima,
Yes, doctor.
you can start.
Hello, everyone. Today I'm going to talk about Truncus arteriosus. So here is the outline for my topic today. Truncus arteriosus is defined as a congenital malformation in which a single arterial trunk arises from the heart, overrides the interventricular septum, and supplies the systemic, pulmonary, and coronary circulations. With Truncus arteriosus, there are no remnants of a separate pulmonary valve or ventricular to pulmonary artery continuity. And this distinguishes the Truncus arteriosus from the severe form of tetralogy flu with pulmonary atresia. Truncus arteriosus is relatively uncommon, representing 0.21 to 0.34% of patients with congenital heart disease. So here is a brief history regarding Truncus arteriosus. The first case was documented by Wilson in 1798. The basic morphologic criteria has been cited by Levin-Safiri in 1942. Classification of Collins and Edward was elicited in 1949, and the first repair with PTFE, the non-valved conduit, was done in 1962. Another or alternative classification has been reported by Vanderpride in 1965, and the use of the first aortic allograft and valved conduit has been done in 1967. So regarding the physiological life of patients with Truncus arteriosus, what has happened is that the incomplete or failed septation of the embryonic Truncus arteriosus or abnormality of the conotruncal septation. As we know, the primitive mesoderm and neural crest cells give rise to the heart and great vessels. And we have the blood islands of cardiogenic plates, which coils at the 20 days of the gestation, and those give the left and right endocardial tubes within the intraembryonic cilium. The right and left endocardial tubes would diffuse at the 23rd day of gestation and forms what is called the pulpus cordis. At this period, pulpoventricular structures rotate anteriorly and to the right to form the heart loop. And then the truncoconal swelling, as well as the truncoconal bridges, would fuse to form the truncal septum, which separates the pulmonary trunk from the aorta. So regarding the anatomy and classification, we know that the single aortopulmonary trunk from the base of the heart would supply all the circulations, the systemic, the pulmonary, and the coronary circulations. We have a large perimembranous VSD below the truncus, and different morphology of the truncal valve. It could be either a tricuspid in about 60% of the cases, quadricuspid valve in 25%, or bicuspid valve in 5% of the cases. So the single arterial trunk would be dominantly positioned over the right ventricle in about 42% of the cases, and would be overriding the left ventricle entirely in 16% of the cases, and it would be shared by the two ventricles in 42% of the cases. There are several anomalies which are associated with Truncus arteriosus, including the coronary anomalies. We either have like a stenotic ostia, a single ostia, giving rise to the right and the left coronary arteries. We either have a high or low take-up of the coronary arteries, abnormal branching in course, like the anterior descending and the circumflex arising from the right coronary artery. The right coronary artery could also arise from the left anterior descending, and they could also have an abnormal course, like the intramuscular. Also, we have other associations with the Truncus arteriosus, like we have right aortic arch in about 30% of the cases, and also an interrupted aortic arch. It also can be associated with some syndromes like DiGeorge syndrome and hypocalcemia, and also different lesions associated with tricuspid valve. So here, coming to the classification of Collins and Edward. In type 1, the Truncus arteriosus, we have the single pulmonary trunk at the lateral side, giving rise to the right and the left pulmonary arteries. In type 2, the two pulmonary arteries are both arising from the posterior aspect of the common trunk, and they have a very proximate origin. In type 3, they are arising from the lateral aspect rather than the posterior aspect of the single trunk. In type 4, rather than arising from the ascending part, they're arising from the descending aorta. And in Vanderpride classification, we have type A1, which resembles or similar to the type 1 classification in Collins and Edward. Type A2 includes both type 2 and type 3 because it's a rare form to be found in rare anatomic variation. So they have been combined into type A2, type 2 and 3 from the Colton Edward. And type A3, we have usually a single pulmonary artery, and usually this is the right pulmonary artery. And on the other side, we have a collaterals supplying the contralateral side of the lung. And in type A4, we have an interrupted aortic arch, unsimilar to the other classifications. So Colton Edward, Van Praagh, and lastly the modified Van Praagh classification. And in the modified Van Praagh classification, we have type A1 and type A2 combined into one category, and A3, A4 are similar to A3 and A4 in Colton Edward. So the overwhelming abnormal pathophysiologic feature of Truncus arteriosus is a large left to right shunt that increases after the neonatal period as the pulmonary vascular resistance falls. And when the pulmonary vascular resistance falls, we would have increased pulmonary blood flow, increased pulmonary venous return, and that would result in congestive cardiac failure. The truncal valve could also have some sort of regurgitation, which might also cause pressure overload in addition to the already existing volume overloaded ventricles. Pulmonary vascular obstructive disease may develop as early as 6 months of age, leading to poor result after delayed surgical correction. So how would those patients present? Usually they would give a history of cyanosis at birth, early signs of congestive cardiac failure, failure to thrive, and respiratory tract infections. Upon examination, they would present with cyanosis, signs of congestive heart failure, single S2, pounding pulses, and pansystolic murmur as they have a VSD, and end-diastolic murmur as they have truncal valve regurgitation. So establishing the work of the diagnosis for those patients would be with doing ABGs, monitoring the oxygen saturation on a pulse oximetry, having an ECG, which usually shows a sinus rhythm and high ventricular hypertrophy in almost 70% of the cases. A chest X-ray would show cardiomegaly, increased pulmonary vascular markings, and absent pulmonary artery segment, and sometimes right aortic arch. An echocardiography test would also be beneficial to determine the type of Truncus arteriosus according to the classification and the origin of the coronary arteries and their proximity to the pulmonary trunk, the character of the truncal valve, and the degree of the truncal insufficiency if it present. An MRI and CT would give more accurate anatomic details such as the coronary artery location and the pulmonary artery origins, which can help in planning the operation. Also, we can have like some sort of cardiac catheterization and helping for diagnosing and to delineate the anatomy and complex forms of Truncus arteriosus, and also to assess the pulmonary vascular resistance in patients with late presentation. Basically, the treatment would be either medical or surgical, and it is very essential that the untreated patients with Truncus arteriosus have a dismal prognosis with a 65% 6-month and 75% in 1-year mortality rate. Medical treatment would include treating the congestive heart failure with diuretics, Jackson, and vasodilator therapy. It would also include providing the required oxygen rate through different ventilating aspects, and also correcting the hypocalcemia syndromic patient. Complete repair can be performed in the first 1 to 2 weeks of life, which has resulted in an improved early and late survival. Regarding the surgical correction, previously there was a surgical correction with pulmonary artery panding, which results in ineffective palliation and high mortality. So the ideal is to go for complete repair, which would usually include the closure of the ventricular septal defect, committing the common arterial trunk to the left ventricle, and reconstructing the right ventricular outflow tract. So here's briefly the steps for the operation in type 1 and 2, because in type 4, in case of interrupted aortic arch, we would have a different surgical correction. We'd start with median sternotomy, mobilizing both canthus pulmonary arteries, and then we'd go for bicaval cannulation, and the patient would be heparinized. Aortic cannula would be placed as distally as possible because we would like to allow enough room for the aortic clamp and pulmonary trunk detachment, and also aortic reconstruction. And type 1 and 2 would go for moderate hypothermia with a temperature of 30 to 32 degrees centigrade, whereas in type 4 with interrupted aortic arch, we would go for deep hypothermic regulation with a temperature of almost 18 to 20 degrees. The pulmonary arteries would be snared to prevent flooding of the lung and to maintain proper perfusion. Would place then an LV vent to minimize venous line air and maximize the intraventricular exposure. A cardiopulmonary bypass would be established and the cardioplegia would be given at this stage. Patients with intact aortic arch can undergo pulmonary trunk constriction, while patients with interrupted aortic arch, here's another difference, will require separate pulmonary artery constriction to maintain the flow through the patent ductus arteriosus. So the pulmonary artery trunk is then removed with a special attention. We would visualize the coronary artery anatomy and the Tranquil valve for any lesions. And at this stage, we would do the proper or the needed replacement or repair for the Tranquil valve. And then the aortic closure can be performed directly or using the BTFE. A separate pericardial patch can also be used to support the closure and also to minimize the bleeding if it is indicated. The distal valve conduit to pulmonary artery anastomosis is then performed with different grafts. We could or different conduits. We could either use a proven internal jugular xenograft, cryopreserved hemograft, and then we could put the sutures with 6-0 Perlin continuous sutures. A care should be taken to perform the anastomosis to the graft close to the valve commissures because this will position the valve distally, thereby minimizing coronary artery and heart compression by prosthetic valve stent. This is followed by right ventriculotomy. We would perform it on the right ventricular parietal wall to create or reconstruct the RVOT. The patient is rewarmed while the proximal anastomosis is completed. And then we would close the VSD, the ventricular septal defect closure with interrupted ligated 5-0 polypropylene sutures and with a VSD patch. If you can see in this picture that the posterior 1/3 position of the homograft annulus is sutured directly to the superior rim of the right ventriculotomy. So ending with air and vent removal are followed by separation from the cardiopulmonary bypass. And for the surgical correction would have the outcome improved greatly after early corrective surgical policies and increased mortality is associated usually with the coexisting anomalies, truncal valve insufficiency, and also the need for truncal valve replacement. The survival rate is estimated to be 90% at 1 year after the surgical correction and 60% at 20 years. And thank you.
Thank you, Fatima. Sure, Dr. Ibrahim, do you have any comment?
Is he still with us?
I think Dr. Abdullah is not here. He's not in the list.
I think he left already.
Yeah.
Dr. Hugir, any comment from your side?
So I would say a very nice presentation. I really enjoyed it. It captures many of the aspects of the issues that you need to learn, in particular for the early intervention. One thing important about the care of the preoperative care of those patients is to avoid full oxygenation of the patient. I'm not sure if I heard the presenter Fatma, if you have mentioned giving those patients oxygen before surgery. So I'm not sure if it's Fatma, right? Fatma Hijab is the presenter.
Yes, Doctor.
Yes, doctor.
Did you have any comment before? I heard that you said in the preoperative management you would give those patients oxygen.
Well, the idea was about like correcting any like oxygen desaturating issues before the operation.
So many times
It's
the
more about
oxygen,
like stabilizing these patients.
the oxygen desaturation of those patients is usually due to heart failure and pulmonary edema. And you have to be careful of giving them oxygen because it will vasodilate the pulmonary circulation and will even flood the lung even worse. And usually the mortality in those patients, either during induction or in the ICU preoperatively, is related to high flow oxygen. So please make sure that you don't give those patients too much oxygen, or room air usually is the intended treatment. So that's one of the comments. About the other issues. The simple form has very good outcome, but you mentioned something about 20 years survival is only 60%. I think this have changed dramatically recently. We don't see as much mortality especially with the simple forms. Thank you. If anybody else have any questions about any of the issues that the presentation in campus? Okay, thank you.
Thank you, Dr. Khalid. Thank you again, Fatma. So since we have finished ahead of time, we'll meet back at 3 p.m. for the special presentation.
By the way, the next presentation by Dr. James Cox is, this is a very famous surgeon who have invented the Cox maze procedure. You should all try to attend and listen to him. It's going to be a very intriguing. And if you have any questions regarding arrhythmia surgery, he will be the world expert in this issue. Thank you.
Hello?
Hello?
Louis?
Yes, hi, Dr. James.
Hi, how are you? Good morning. Or good
morning.
afternoon there, I suppose.
Yeah, it's an afternoon here.
Yeah.
Good morning to you.
Well, thank you.
Thank you very much for joining us today.
Oh, well, I'm honored to do so. I am trying to start my video.
Yeah, you can start share your presentation.
Can you see me now?
Yeah, I can see you.
Okay. So I cannot see you. So,
See me now?
Yes.
Yeah.
Nice looking young man.
Thank
Okay,
you.
now, how am I going to show you my slides? Because you wanted me to show some slides early, right?
Yeah. I believe you can, there's a, like, on top of the screen, you can see there is a button for sharing.
Oh, yeah, that's on the bottom. Yeah. Okay. All right. Oh, you know what? I need to pull those slides up first. Sorry. I had them up and was looking at them earlier. Okay, so let's go back to not share screen for a second. Let's see. Okay, you can see me and I can see you, right?
Yeah.
All right, so let me pull this up. Oops. How long does this conference last?
Well, we have maybe 2 hours from
Okay.
3 o'clock. Yeah, from 8 o'clock.
Okay, so this talk will be about first half hour, 45 minutes. Is that all right?
Yeah, sure.
I've had a little trouble with my internet this morning. Let's see. And also with PowerPoint. I'm not sure why. Okay. Now let's try to share. Now let's share the screen. Okay.
Yeah, I can see your screen now.
Okay. Can you see my slides?
Yeah.
Okay. So if I put it in, so you can see that slide in full screen.
No, still not in full screen.
Sorry.
It's not in full screen yet.
Oh, well, I went to slideshow. Let's see. So you don't see that blue slide there?
Yeah, I can't see that all the slides on the side. So it's not in the presentation.
Okay. It's not in the communication?
Yeah,
Well,
you need to press the presentation or mode.
That's what I did. That's exactly what I did. On my screen,
Yeah.
I can see my slides, you know, on the left, and I can see you and me on the right.
Yeah, we see the same thing here.
Okay, but
So
then
we can't see.
then if I go to slideshow, my entire screen is just the slide. Well, at least it is on that. You know, I'm looking at two different things here. I have my computer open on my computer laptop, and I also have big projector there, and on a separate big screen.
Okay.
And on my big screen, I see the presentation mode, but on my computer, I don't. So let me do this. Let me disconnect that big screen. What do you see now? The same?
Now I can see there are two big slides, and the other slides are on the bottom.
Yeah, okay, so you're seeing the same thing I am then. And I'm not sure why I can't get this in big.
There is a use slideshow on the top left. Maybe this would help.
There it is, yeah.
Maybe this one.
That's what I was looking for. Now you can see it full screen?
Yeah, you can see it full.
All right, and let's make sure the animations work. Let's see. You know, I need to get this thing smaller. Hide selfie. Okay, so I'm going to hide this for the time. Can you still see me?
Yeah, I can see it. I can see the slide as well.
Oh, wait. Okay, you can see me and the slide there, right?
Yeah.
Is it blotting out any of the slide?
No.
Here we go. This is what I want right here. No. Because there's something on the right of that slide that you need to see.
Well, I can see your picture on the bottom right, and it's not blocking anything of the slide.
It's not?
No. At least for this slide. I'm not sure about the others. It's going to block anything or not.
So you don't, oops. Yeah, it's not working either. Yeah, okay, hold on. Do you see the +2s appearing there?
Yeah.
You did. You saw them all appearing there?
Yeah, I saw them all.
See, I can't see them on my slide because this thing is in the way. And I'm not sure how to get it out of the way. There, I was able to move it. Okay. No, it wasn't either. It won't stay there. Okay. Can you still see me?
Yeah.
Oh, okay. Well, we'll have to do it this way then, because you can see the animations on my slide, right?
Yeah, I can't see them.
Okay, I just can't see you when I'm giving this, and that's or myself either, so that's okay. All right, so we'll start right there, and you can see me, and I have my slide up, correct?
Correct.
Okay, good. And we made it by 3 minutes, right?
Yeah, we'll still have 3 minutes, so maybe for others to join.
Okay, well, you tell me when you'd like to start, okay?
Sure.
So tell me about yourself. What year are you in?
So I'm currently in 5th year. We have, our program is 7-year program here in Saudi Arabia.
Mm-hmm.
It's a direct cardiac surgery program. We don't have to do a general surgery first. So,
mm-hmm. Yeah, we do. Yeah.
I'm at King Faisal Hospital. I'm not sure, have you been there or not before?
No, I've not been there. I've been all around there, but I've not well, not all around there. I've not, I've never been there. Is this the same place that Tommy Mihalovich was before, from the Cleveland Clinic?
I'm not quite sure,
Not
but I
sure.
don't believe he was there.
And the guy that runs the Cleveland Clinic now spent several years there in Riyadh. You're in Riyadh, right?
Yeah, on Riyadh.
Yeah. Yeah.
But we have residents from all around the kingdom,
Right.
from Eastern Province, Western Province, from Dammam, Jeddah.
And your cardiac surgery program is pretty active?
Yeah, still in the progress of development, but it's an active program, yeah.
Well, the reason I'm having a little trouble with my internet is I'm actually on vacation, on holiday, and I'm in Florida, and so it's not quite as, the internet's not quite as good when you're about 5 minutes from the beach as it is when you're in the middle of Chicago.
Of course. Seems that's working fine right now.
Oh, good. Well, I hope it keeps that way.
All right. Yeah, I think we can start now. Just want to give a small introduction. I would like to welcome Dr. James Cox, who was humble enough to accept our invitation for today. Dr. James Cox is a pioneer. He did his medical school education at the University of Tennessee, and then he joined Duke University, where he did his surgical residency. And then he joined the same university as an associate professor of surgery. He also served as a cardiothoracic surgeon at different institutes and university across the United States. He's a known figure of cardiac surgery for his great work in arrhythmia surgery, and probably you all know him from his great work for Cox-Maze procedure. So again, I would like to welcome you, Dr. James Cox, and thank you very much for accepting this invitation, given that you're on holiday. And without further ado, the mic is yours. Thank you very much.
Thank you very much, Louis. I am very honored to be invited to speak to you today. And I wasn't sure exactly how you wanted this set up. So what I've done is I've put together some slides and give you an overview of how I see the problem of atrial fibrillation. And I understand we have a couple of, maybe a couple of hours. The talk is probably 30 or 45 minutes, but I'll try to keep you awake and interested. And once that's over, then we'll have plenty of time, it seems, for questions and answers. So the title of my talk this morning is Contemporary Interventional Therapy for Atrial Fibrillation. The, whoops, let me get my, okay. I think the first question to ask is just how bad is atrial fibrillation? Because a lot of people think that, that it's a rather innocuous disease. But in fact, if you look at the incidence of atrial fibrillation and the projected incidence by 2050, these are 4 different studies that have been done in the past, and all of them have one thing in common. Even though the numbers are different, they all have one thing in common. If you look at the year 2021 here, the generally accepted one is the one in blue, and the numbers are around 3 to 3.5 million patients in the United States. Now, the United States has about 340 million people, and that's roughly 1% of the general population, and that's the generally accepted number. If you want to know how many people have atrial fibrillation in a given country, it's generally around 1%. It varies a lot, but it's generally around 1%. That's projected to, regardless of which one of these studies you look at and which numbers you accept, the numbers are expected to double by 2050, which is another 30 years. So there's no question this is a serious problem from the standpoint of its incidence and prevalence in the general population. But here's something you probably didn't know. This is a list of the 5-year survival rates for the most common, 25 most common cancers in the United States. Starting with pancreas has the worst survival rate, mesothelioma the next worst, and so on. These are 5-year survival rates. Excuse me. If you put atrial fibrillation in there, it would be it would fall into the position of being the 11th. If it were a cancer, if you considered it a cancer of the heart, it'd be the 11th most deadly cancer. And that the survival rate, once the diagnosis of atrial fibrillation is made in the Medicare population, the 5-year survival rate after that is about 50%. That's worse than melanoma, and it's worse than breast cancer in women. So it is a serious problem. The overall 5-year survival rate compared to the overall 5-year survival rate for all cancers are very similar, as you can see in this lower bar. The other thing that was found in some of these studies is that atrial fibrillation is much more deadly in women than it is in men. And we're not sure why that is. Actually, we have no idea why that is. But if you look at a patient who 20 years survival rate in women after atrial fibrillation is only about 10%. And interestingly enough, my mother died of atrial fibrillation, so she would have fallen into this category when she was 73. The main reason people die after atrial fibrillation is strokes, and we all know that strokes are associated with the atrial fibrillation. If you look at all strokes that occur, those with and without atrial fib, about 90% of them are ischemic, and about 10% of them are hemorrhagic. If you look at the ischemic strokes, which are the worst ones with atrial fibrillation, of course, about 20% of all ischemic strokes in the United States and Western Europe are associated with atrial fibrillation. That translates in the United States to about 130,000 strokes per year due to atrial fibrillation or associated with it, and about 240,000 strokes a year in Europe. This is a much higher incidence in Europe. Again, we're not sure why, but it's almost an epidemic there in patients who have atrial fibrillation. I'm going to briefly go through the classification of atrial fibrillation, because one thing I always tell my residents and colleagues is that atrial fibrillation is a lot simpler than the cardiologist would sometimes want you to believe. It's not a simple arrhythmia, but it is a simple arrhythmia from the standpoint of how you can treat it interventionally. Paroxysmal atrial fibrillation, this is the classification we use. Paroxysmal atrial fibrillation, or PAF, occurs intermittently, and each episode lasts less than a week, and that's the definition. Note there's no anatomy or physiology involved. Non-paroxysmal atrial fibrillation, that is persistent and long-standing persistent atrial fibrillation. The persistent episodes last over a week, but less than a year, and long-standing persistent episodes last over a year. So you can see that this entire classification system that we've now used for the last 15 years or so is based not on the anatomy of the atria or the physiology of the atrial fib or anything else. It's based on how long the episodes of atrial fibrillation last. Now, that's a great classification, I think, if you're treating the patients with drugs. But when you're treating them interventionally, it can be fairly inadequate in terms of the classification. We'll get into that more later. But using that classification, if you take the general population, about and look at the number or percentage who have PAF, about 60% of the people have PAF, and the other 40% have something else, which is non-PAF or persistent, longstanding persistent. Now you hear the term standalone atrial fibrillation a lot. Standalone atrial fib means that the atrial fib occurs in the absence of any other heart disease serious enough to warrant cardiac surgery. So that entails about 97% of all the people with atrial fibrillation. The other 3% of the people have what we call concomitant AF. That is, it's associated with some other cardiac condition that requires surgery, like CABG or mitral valve disease or aortic valve disease. And of course, that's the other 3%. So we have these four categories, basically, 2 in standalone AF and 2 in concomitant. In standalone AF, you can have standalone paroxysmal AFib. That is, a person has intermittent atrial fibrillation, but nothing else is wrong with him for the heart. Or you have standalone non-PAF. A patient can present to you and say, "Doc, I've had atrial fibrillation for the last 3 years, and nothing else. You can find nothing else structurally wrong with the heart." Likewise, patients who are coming for, let's say, a mitral valve operation can have paroxysmal atrial fibrillation, so that would be concomitant PAF, or they can have continuous atrial fibrillation or persistent, long-standing persistent AF for several months or several years. Standalone AF, if it requires intervention, is virtually always by catheter ablation. Concomitant AF is that AF that occurs in patients that we're already going to operate on for some other reason. So we as surgeons will be the ones who take care of the concomitant AF. Because the catheter ablations for standalone non-PAF are not very good, over the last 10 years or so, we've added hybrid procedures where both the cardiologist, electrophysiologist, and the surgeon are involved in the interventional treatment. So let's look at the electrophysiology and so on. As I said, it's not as complex as you'd like it, as some people would like to make it in terms of what you can do interventionally. Let's take a patient, for example, in paroxysmal atrial fibrillation. That patient normally, most of the time, is in a normal sinus rhythm. He then has a trigger that fires. It's a premature beat is what it is. It's a simple premature atrial beat that occurs in the atrium, and it's usually in and around the pulmonary veins. We'll get into that more later. And that trigger induces the atrial fibrillation. So this is atrial fibrillation here. This is not atrial fibrillation. This is a trigger that induces the atrial fibrillation. And most of these episodes are self-limiting, and they stop after a period of time, usually after a few hours or maybe a few days. But they stop within 1 week, because that's the definition of paroxysmal. And when it stops, the patient goes back into normal sinus rhythm. So this is the cycle. Normal sinus rhythm most of the time, trigger in the atrium, usually around the pulmonary veins, induces an episode of a self-limiting episode of atrial fibrillation. It either spontaneously stops or responds to medicine, and then it goes back into sinus rhythm. That's paroxysmal atrial fibrillation. All other forms of atrial fibrillation represent something entirely different than paroxysmal atrial fib. So if we look back at our classification again, then we're talking about standalone paroxysmal atrial fibrillation. That's what the physiology I just showed you was. We know that about 90% of the triggers that induce those episodes of atrial fibrillation are located in and around the pulmonary veins. Not necessarily in the pulmonary veins, as Hoskier initially reported, but in and around the pulmonary veins. 90%. So if you encompassed a box or an enclosure around all 4 pulmonary veins, including the posterior left atrial wall between the right and left pulmonary veins, then you would take out 90%, roughly 90% of the triggers that induce atrial fibrillation. That atrium can still fibrillate if it's given a trigger from somewhere else, but 90% of those triggers are located in and around the pulmonary veins. That type approach, that is doing a pulmonary vein isolation without including the posterior pulmonary veins, posterior left atrial wall, for standalone PAF is very effective. For example, if you do a single catheter ablation, follow those patients for 5 years, the success rate is about 50% after 5 years for paroxysmal AFib. If you do multiple catheter ablations, which most of these people get actually, then it's up to, it's up to 80%. So this is a very good treatment. That is catheter pulmonary vein isolation. It's a very good treatment for standalone paroxysmal atrial fibrillation. If you look at the type atrial fibrillation that we see associated with mitral and with valvular and coronary heart disease, that number is not 90%, it's 70%. So only about 70% of the triggers that induce these episodes of paroxysmal atrial fibrillation, let's say in a mitral valve patient, are located in and around the pulmonary veins. So obviously, if you encircle the pulmonary veins and the posterior wall and so forth, and concomitant AF, you will not get as good a results as you would if those patients had nothing else wrong with their heart. So the question comes, where are these triggers actually located in the patients that we see as surgeons, that is in concomitant PAF? Well, I mentioned that 70% of them are in and around the pulmonary veins. And if you look and see where they're actually located, about 20% are located in the posterior left atrial wall between the pulmonary veins. The distribution between the pulmonary veins is more or less equal, so that would leave 70% minus 20%, that would leave 50%, 25% in each pair of pulmonary vein areas, okay? So 25, 25 is 50, 20 is 70, so that's the 70%, okay? Another roughly 10% are located in the left atrial appendage. So that's 70% plus 10 is 80. And the other 20% can be located anywhere else in the atrium, even in the right atrium. And I'm not sure why there we go. So we know from experience in doing different operations for this paroxysmal atrial fibrillation, that tells you where these, what the distribution of these triggers is, and this is it. So you can calculate from this how many of these patients you're likely to cure by doing certain types of lesions in the atrium. Now that's paroxysmal atrial fibrillation that's induced by triggers. Let's look at non-paroxysmal atrial fibrillation. Non-paroxysmal atrial fibrillation is different from paroxysmal because once this episode starts, it doesn't stop. And then you get what's called either persistent AFib, which lasts, as I said, up to a week, or long-standing persistent that lasts up to a year or more. Once that atrial fibrillation episode is started, and these reentrant circuits can be self-perpetuating, they're being self-perpetuated because of the abnormal physiology that allows these things to just start and then stay there. It may have been induced originally by a trigger, but it's been there now for 3 years, let's say. The triggers no longer have anything whatsoever to do with this atrial fibrillation. So isolating the triggers is not going to have any effect at all essentially no effect on these patients who have been in persistent or long-standing persistent atrial fibrillation. It can help some with persistent, but not very much. But certainly the long-standing persistent AF, the triggers have absolutely nothing to do with it. So what are we looking at? Well, the map I just showed you that's swirling around is called a phase map. It's a computerized demonstration of the activation of the atrium. But if you want to see the electrophysiology of atrial fibrillation, you have three choices. You can look at activation time maps, you can look at voltage maps, or you can look at phase maps. And the phase maps are relatively new and not very helpful. Voltage maps is what you see most of the time when you're reading papers in the literature. But when you see a map in a paper in literature, always look and see if it's a voltage map or if it's an activation time map, because you will never see reentrant circuits in a voltage map. They're incapable of showing it. For the first 100 years or so of mapping of atrial fibrillation or any other arrhythmia, the only thing we used was activation time maps. So with the activation time maps, if you map atrial fibrillation, which we started doing about 35 years ago with computers, what you find are these large reentrant circuits or macro reentrant circuits that spin around in the atrium, and they're usually in specific sites. These red rings that I'm showing you here are not cartoons totally, because every one of them has been described in the literature, and no other reentrant circuits have been described. Well, a few other reentrant circuits have been described, but essentially this is it. So if you know that these are the potential sites of the reentrant circuits that are driving the persistent, long-standing persistent AF, then you can figure out what lesions placed in various areas will do to it. For example, pulmonary vein isolation when the box lesion, including the posterior left atrial wall, is very good, very effective for paroxysmal atrial fibrillation. Let's see what it would do for long-standing persistent. Because the idea is if you put lines of conduction block, that is with a catheter or with a knife or with a cryoprobe, you put them close enough so that these big reentrant circuits can't form. And if these big reentrant circuits can't form, then by definition, the atrium cannot fibrillate. Because rather than call it atrial fibrillation, we should call it atrial macro reentry. That would make everything a lot simpler, I think. But nevertheless, that's the objective of the intervention in persistent and long-standing persistent AF, or it should be. If you're dealing with standalone non-PAF or concomitant non-PAF, the physiology is exactly the same. And so the treatments, the results will give you the same. Let's look and see what happens if we do a box lesion around all four pulmonary veins, including the posterior left atrial wall, in a patient, in patients with long-standing persistent AF. Well, that knocks out this reentrant circuit, this one, and this one. So you will get some benefit. Maybe 30% of the patients will have reentrant circuits involving this posterior left atrial wall. But look at all these other potential reentrant circuits. And if you have two or more reentrant circuits in either atrium at the same time, that's atrial fibrillation. So clearly, this is not going to cure most of the atrial fibrillation that is persistent, has been around for a year or two. In fact, if you look at what a pulmonary vein isolation, the results of pulmonary vein isolation for non-paroxysmal atrial fibrillation, that was reported by Karl-Heinz Cook's group in Germany a few years ago. And it's the only such study that has long-term follow-up in the literature. And you'll see that with a single catheter ablation, this was pulmonary vein isolation, at 5 years, the success rate's 20%. If you do multiple catheter ablations, the 5-year success rate is 45%. Now, if these were surgical results, you probably would lose your job. But the thing that surprised me about this is that this slide shows you that with multiple catheter ablations, almost half of patients with atrial fibrillation for 2 or 3 years can be cured. And I find that quite remarkable. I think that's amazingly good, not amazingly bad as surgery would be if you had this type of results. And it should factor into how you treat patients, and it does, and we'll talk about that in a little while. I'm having trouble advancing again. Let's see. So if you look at PVI for concomitant non-paroxysmal atrial fibrillation, you'll get exactly the same results. So for example, if you have a patient with mitral valve disease who has been in atrial fibrillation for, let's say, the past 2 years, and you decide I'm going to do something to treat the atrial fibrillation, and that something is a pulmonary vein isolation or a box lesion around the back of the atrium, you'll get at 5 years, 80% of them will be back in atrial fibrillation. So the summary of the interventional treatment objectives are very simple. If the patient has paroxysmal atrial fibrillation, then you want to isolate the pulmonary veins and the posterior wall of the left atrium. If the patient has persistent, long-standing, persistent, or permanent is described as long-standing, persistent that can't be electrically cardioverted, categorized as non-paroxysmal atrial fibrillation, then the objective is not to isolate the triggers. The objective is to interrupt the drivers. So you have to put lesions in here that in such a position and close enough together that will do two things. One, that it will ablate the atrial fibrillation. That's number one. But just as importantly, it will leave the atrium capable of responding and being activated by a normal sinus rhythm beat. Very simple objectives. Now, these aren't categories of paroxysmal and non-paroxysmal aren't really categories that are specifically divided with lines that you can draw between them. They're transitions. So we transition from paroxysmal atrial fibrillation that initiates atrial fibrillation. It's caused by triggers. You transition into persistent and then long-standing persistent atrial fibrillation in which the drivers, the macroenteric drivers, are maintaining the atrial fibrillation. So paroxysmal transitions, persistent is sort of in the middle, permanent, the importance of the triggers in permanent is nil, and so on. So this is a transitional problem between these categories. Generally speaking, paroxysmal is treated with catheter PVI. If it's been there a little longer, it's catheter PVI plus various other things that can be added to it. We now have inserted hybrid procedures in here for the persistent and early permanent or long-standing persistent. And then the maze procedure, which we'll talk about later, is reserved for the long-standing persistent for most part. Now let's look at some of the limitations of catheter ablation. And in fairness, we're going to look at the limitations of surgical ablation later. If this is the atrial wall and electrical activity is coming through it like this, what we want to do to stop this is we want to make the ideal lesion. That ideal lesion would block that conduction, and it has to be contiguous. There can't be any gaps in that lesion, and that lesion has to be uniformly transmural. And that will stop the electrical conduction. Problem with catheter ablation is that it's applied by the tip of a catheter. So you will have areas that are killed by the radio frequency here and areas that are just damaged by the radio frequency. And if you do a test on this immediately after the procedure is done, this tissue here will not conduct either. It's not dead, but it's been damaged enough by the procedure that it will not conduct electrical activity if you test the procedure immediately after completing it. So you'll say, okay, it's fine. We've isolated the pulmonary veins. We have complete conduction block. Everything's fine. Let's go home. Let's go to the next patient. The problem is that with time, let's say several weeks later, a lot of these areas that are just reversibly injured will recover and they will be able to conduct electrical activity again. They recover and they're either non-transmural or they're non-contiguous, have gaps in them. And of course, electrical activity will recur. And that's why catheter ablation fails so often for various types of atrial fibrillation. This is an EP's concept of catheter ablation. This is another problem with it. When you're doing it on the screen and everything, you're looking at voltage maps for the most part, and you look at where you're putting the lesions. And I've always asked my electrophysiologist, even your computer screens showing you that you're not contiguous. I mean, these are gaps. These can conduct electrical activity. If you then later go in and have to do surgery on patients who've had previous catheter ablations where they thought they were doing this is what you find. And you don't find this sometimes, you find it every time. And that is just sort of what appears to be almost a random scattering of lesions in the atrium, some of which are transmural, some of which are not, most of which have gaps between them, and so on. So this is what you find actually, because the scars that you see as a surgeon later on don't lie. They show you exactly where the radiofrequency ablation was occurring. Otherwise, there wouldn't be a scar there. And I've looked inside lots of left atria in my life that have undergone catheter ablation. I've never once seen anything that resembled a line. Hasegaer told me one time that it's almost impossible to create a line with the tip of a catheter that's 80 centimeters long. And I think he's absolutely correct. I think a lot of times the reason this works is because you're actually ablating a lot of those triggers, because we know that it works. For example, this operation is an extremely successful operation for paroxysmal atrial fibrillation because it isolates the triggers that are in here, and you can show later that the area is isolated. So I think a lot of it is because you're ablating it. Some of it's because you're isolating it, but whatever, it seems to work for paroxysmal. But this is an example of what we see at the time of surgery. These are endocardial lesions that have been placed by catheter ablation. You can see there are gaps between them, and you can see that most of them are not transmural. So this is what I'm talking about. As I said, Michel Hasegaer and I we had dinner once a few years ago in Bordeaux, and he said trying to create a line with the tip of a catheter is like trying to cut off the corner of a sheet of paper with a straight pen. It's virtually impossible to do it. And I said, I'm going to quote you on that, Michel, and so I've quoted him on it ever since. Because these lesions can be put basically anywhere you want, and because these lesions with catheter ablation aren't really where you think they are, it can lead to a lot of serious misinterpretation. This is the famous STAR Af2 trial, and I actually debated my friend Atul Verma, who I think is absolutely brilliant, on this in Venice a couple of years ago. Nevertheless, this is the STAR Af2 trial. And in the STAR Af2 trial, it's a very famous trial in medicine, there were three groups of patients: patients who had pulmonary vein isolation, patients who had pulmonary vein isolation plus Cath ablation. Cath is continuous fractionated atrial electrical activity, and pulmonary vein isolation plus lines. And the lines were one across the roof and one from the left inferior pulmonary vein down to the coronary, down to the mitral annulus. Now, the reason I went through this business about where the actual lesions are is that if you went inside and looked at these patients after this procedure, the inside of the atrium would look something like this after pulmonary vein isolation. How do we know that? Because you've seen hundreds of them that way. If you then added Cath ablation to that pulmonary vein isolation, the inside of the atrium is going to look like this. That is, it's going to look exactly the same. If you look at it in this group of patients with the lines, it's going to look exactly, you'll have a little bit more burning up here and a little bit more back here, but for all practical purposes, it's the same operation. So when the results were reported for pulmonary vein isolation, isolation plus Cath ablation, and isolation plus lines, they all came out the same. We found no reduction in the rate of recurrence of atrial fib with either linear ablation or ablation of complex fractionated electrograms was performed in addition to pulmonary vein isolation. You know, why would you be surprised at that? You're getting the same operation. If you look at PVI plus lines for non-paroxysmal atrial fibrillation, this is the PVI, including the posterior wall. If you're going to get that, if you're going to prevent that reentrant circuit from occurring, that's using the Coumadin ridge, then you have to go across the Coumadin ridge with a line. Now this line's not this long, but that's the only way you can stop that reentrant circuit. You can stop this one, of course, by isolating the left atrial appendage. But these down here, these are perimitral flutter, the big thick ones. This reentrant circuit we found on the very first patient ever to undergo computerized mapping during atrial fibrillation. Put a line down to the mitral annulus that interrupts those reentrant circuits, and if you have to freeze the coronary sinus in the same spot, and it interrupts that one. So now you've done a left-sided procedure, but you still have 30% of the patients have drivers like this in the right atrium. So an intercaval lesion takes care of that reentrant circuit, that one, and that one. A lesion around here to the tricuspid valve takes care of one around the orifice of the tricuspid valve, and a lesion up there gets one around the base of the atrial appendage. And if you look at that, that's what the maze procedure is. And the reason we put all those lesions in the maze procedure are for the reasons I just pointed out. Excuse me. But not only do those lesions have to be placed in the right position, but each one of those lines has to be contiguous and transmural. Every line must be placed in the correct position. Every line must be contiguous and transmural. If either one of these principles is violated, then your results drop from the high 90s down to the 60s and 70s. Most importantly, this particular way of putting these lesions in here allows the sinus node to drive the atrium in both atria, except for the isolated portion around the pulmonary veins. What about the limitations of surgical ablation? Well, the limitations of surgical ablation are exactly the same. If you put, let's say, a cryoprobe in, or you make an incision with a knife that doesn't go all the way to the annulus, or you use a unipolar device, which should never be used, a unipolar device, if you can avoid it, you will have the same problem. You'll have dead tissue, and you'll have tissue that's damaged but viable and can't conduct electrical activity. So if you do intraoperative testing immediately after these lesions are created, you'll see complete conduction block. But again, several weeks later, some of those areas that are not transmural may recur and allow you to have conduction, and that allows you to have atrial fibrillation again, so you get a failure of the procedure. So you have the same problems in surgical ablation that you have in catheter ablation. They're just a little less common, that's all. Now, you remember I said that, well, I won't go all the way back. Remember I said there are two things. These lesions have to be contiguous and uniformly transmural, both. But they also have to be put in the correct locations. And if you violate either one of those, you won't have as good a results. These are the surgical lesions, the patterns of surgical lesions that have been reported in the literature over the last 20 years. This is 19 of them. There have been a lot more. But why anyone would think this lesion would cure atrial fibrillation is a mystery to me. Of course, this is pulmonary vein isolation. It's pulmonary vein isolation with a box lesion around the posterior pulmonary veins and so on. But these are just bizarre, and none of these things have had any kind of, except for the pulmonary vein isolation, have any kind of real electrophysiologic studies underlying them. Certainly not something like this. Not one of these is a maze procedure. And when people go in and do anything to the atrium, it's unfortunately called a maze procedure. So you do a procedure like this, and you say, I did a maze procedure on that patient, it failed. Well, and I'm sorry, that was not a maze procedure. It's like saying, I drank a Coke, but it tasted funny. Well, it was because it was a Pepsi, it wasn't a Coke. And so you either do a maze procedure correctly or you don't. Not one of these is a maze procedure. For example, this is the so-called Wolf mini maze procedure. It's a pulmonary vein isolation with clamps and an excision of the left atrial appendage. It has absolutely nothing to do with a maze procedure. So I've always fussed at Randy for using that terminology. You hear patients say, well, I did a left-sided maze on the patient. Well, that's a left-sided maze. Those are the patterns of the left atrial patterns of a maze, but you still have 30%. You've got a built-in 30% failure rate here. That's not a maze procedure. The Dallas lesion set was a left-sided only, where the mitral line and coronary sinus lesion were eliminated in this line anterior. This is perfectly fine. This line, the only reason this is put back here is to stop perimitral flutter. And you can stop it up here just as well. And I told Jimmy Edgerton once, I said, if you will add the right atrial lesions to that, I'll call that a maze 6 or something, because you would be fine in doing that, because you've adhered to the principle of putting a maze lesion pattern there that allows the atrium to beat in the sinus rhythm later, but not the case. This is not a maze procedure. Now, the STAR Af2 equivalent in surgery was this paper that was published in 2015. Note that both of them were published in the New England Journal. And I had a lot of my friends' names on it. Well, at least they used to be my friends. I'm not so sure they are anymore because I've castigated this study so much. But this was surgical ablation of atrial fibrillation during mitral valve surgery. And it showed exactly what everybody hoped it would. That is, that if you treat atrial fibrillation at the time of, let's say, of mitral valve repair or replacement, then those patients have less atrial fibrillation post-op and they do better. The problem is they did 2 different operations in this. One was a pulmonary vein isolation, and one was what they called a maze procedure. One group had the pulmonary vein isolation. This is what was called the maze procedure. The problem with this is it's not a maze procedure. But the results of this study were suggested that pulmonary vein isolation was just as good as a biatrial maze procedure, and they were not comparing it to a correctly performed maze procedure. There have been 4 procedures that can legally or rightfully be called maze procedures. The original one, the first modification of it, the maze 2, and then finally the one we settled on in 1992, almost 30 years ago, the maze 3, and Ralph Damiano introduced the maze 4. These are absolutely identical procedures. You just form the box in a different way. but these are of historical interest only. These, the Maze 3 or the Maze 4, and we call it, most of us call it the Maze 3/4. For example, Nevad, who I'm sure you're familiar with, does the Maze 3 and all of his minimally invasive Maze procedures. Ralph Damiano and most others do the Maze 4 procedure because it's considered to be a little bit easier to do. So what are our surgical options? We'll close with the surgical options. What are the surgical options? Well, if the patient has paroxysmal atrial fibrillation and is undergoing either a CABG procedure or an AVR procedure, we do know that we normally do not open the left atrium for either one of these procedures. The patient has intermittent atrial fibrillation. Well, we're dealing with this problem, right? 70% of the triggers are in and around the pulmonary veins. So the surgical options are you can ignore it, you're going to have the same amount of PAF afterwards, and you have no stroke protection. Because the stroke protection comes from including that atrial appendage. So that's one option. That's the option that's most commonly taken, at least in the United States. Most surgeons don't treat atrial fibrillation at the time of mitral valve repair or CABG, rather, in aortic valve replacement. You can just put a clip on the left atrial appendage, and that'll give you how many, that'll isolate how many of your triggers, about 10%. About 10%. So theoretically, you'll have 10% less PAF later, and you do have stroke protection. You can do a pulmonary vein isolation and a left atrial appendage occlusion. So you got 10% plus 50% is 60% less PAF, stroke protection. You can do a box lesion that gets another 20% to the posterior wall. Now you're up to 80% less PAF. Or you can do a Maze procedure, which is over 90%. Why would a Maze procedure work? A Maze procedure works because the atrium can't fibrillate after a properly performed Maze procedure. It doesn't have anything to do with the triggers. It has to do with the fact that they can't induce atrial fibrillation because atrial fibrillation cannot be induced. So those are your surgical options. What are the viable options for PAF patients undergoing CABG or AVR? I think there are two. A box lesion will get rid of 80% of your atrial fibrillation, and you don't have to open the left atrium to do this. A Maze procedure, of course, requires opening the left atrium, and most surgeons don't want to open the left atrium when they're doing a CABG or an aortic valve replacement. Most experienced surgeons, the ones that you know from the literature, all of them do a full Maze procedure. You have atrial fib, you get a Maze procedure, period. But it is reasonable, I think, in this one group of patients, or these two groups of patients, CABGs and AVRs, who have paroxysmal atrial fib, I think it's reasonable to do a box lesion and do this, clip the atrial appendage. Now, a box lesion requires a unipolar device to be used for the roof lesion and the floor lesion. And so you're going to miss some of those because the unipolar devices aren't as effective as the bipolar clamps that are used to put around the pulmonary veins. What about mitral valve patients? Well, you're going to have to open the left atrium to do a mitral valve operation. And even if they have PAF, I think the only viable option is to do a Maze procedure because you've already got the left atrium open. It adds about 15 minutes to the operation, 15 to 20 minutes. So a Maze procedure is the option there. What about non-PAF? This is a more complex problem because now you're doing a CABG or aortic valve patient who has been in atrial fibrillation for the last 2 or 3 years. And let me see how we're doing on time. And I'm going to be finished here in a minute. In these patients, the surgical options are simply pretty much the same, except the numbers are a little different. Okay, so if you do a left atrial Maze, for example, you get 70% less. Why? Because 30% of the drivers are over here on the right side. If you do a Maze procedure, you get the better result. So in CABG or AVR patients with long-standing persistent atrial fibrillation, I think all of them should have a maze procedure, and most authorities agree with that. What about mitral valve patients? Non-paroxysmal. Again, you've got the atrium open, and the only thing that's going to work is a maze procedure. So in summary, if the patient has PAF, CABG, or AVR, a box lesion plus a left atrial appendage occlusion will get 80% of them. Mitral valve procedure, if they're having mitral valve surgery with PAF, and they need a maze procedure. For non-PAF, CABG, AVR, mitral valve, they have non-PAF, you have to do a maze procedure. I think what I'm going to do is, let me ask Louis, would you, I have a little bit here about hybrid procedures, but I've talked for about 45 minutes now. So would you like to stop and have some questions and answers, or go on with the hybrid procedures?
Yeah, maybe we can continue and have the questions at the end.
Okay. Let's see. I may have. Can you see that?
Yeah, we can.
That's in the okay, fine. So this is something that faces us often. What are the options for a failed catheter ablation? Because almost all these patients have had some attempt at catheter ablation, and they failed. If they fail, and they have standalone AFib. This is for standalone AFib, and it's for standalone non-paroxysmal AFib, the lower left box. What are the options? Well, one option is for the cardiologist to resume medical treatment and tell the patient to get used to having his atrial fib. Another is to do a His bundle ablation and put a pacemaker in. We did this back as far as Dr. Seeley did back in 1973, 50 years ago. You can do a minimally invasive cryomaze 3 procedure, which we developed in 1997 when Nevad was my fellow in Washington, D.C. And that's what he still uses. And the other option that has come about since roughly 2010 have been the so-called hybrid procedures. Well, let's look at this one that we developed back in the late 90s as a minimally invasive approach using not cut and sew techniques, but cryosurgery techniques. All the lesions were created using a cryoprobe. And one of the misconceptions is that the Maze 3 procedure is synonymous with the cut and sew procedure that was the old original one. That's incorrect. The Maze 3 procedure is a lesion pattern. And the first 5 years, actually 4 years, that we did that procedure, from 5 years, from 92 to 97, we did a cut and sew technique. After 1997, we started using cryo and started doing all of them, essentially all of them, through a small right mini thoracotomy. It was still a Maze 3, but it was done with cryoprobes. Small incision in the 4th interspace on the right side, and cannulated the groin or the axillary artery one. Nevad has continued to do that for the last 25 years now. And these are his results. He has 80% success. And these are in failed catheter ablation procedures for standalone atrial fibrillation, for standalone long-standing persistent atrial fibrillation that have failed catheter ablation. Success rate's 80%. That's the best in the literature. Hybrid procedures, there's several hybrid procedures. What I call the Brescia hybrid, this is Brescia, Italy. Claudio Munaretto reported this one first. Mark Lemire and his colleagues at Maastricht and now in Brussels reported this one first. Bart van Put in Belgium has done, and I'm sorry, the Netherlands has done most of these. I I wrote a paper a couple of years ago on a hybrid maze procedure. And then more recently, the convergent hybrid procedure has gained a lot of popularity in the United States and Western Europe now. So let's look at these. This is a photograph that I borrowed from Claudio Munaretta, and it shows the incisions that are used for the Brescia hybrid procedure. And this is all you do to the patient. You cannot, one of the problems of this procedure is you can't include the left atrial appendage because these are all done off pump, of course, and you can't get the left atrial appendage from the right side off pump. He used an AtriCure fusion device that has a vacuum that sucks the left atrial wall up into the inside of the device and then applies energy from both sides. That would be bipolar radio frequency energy. It can also apply unipolar energy from these lower electrodes across this little curve in the edge here too. Now, he does a very wide encircling maneuver around the pulmonary, the box lesion around the pulmonary veins. And I've scrubbed in with him twice on these procedures going back to 2012. And what he does, he takes the long device and crosses the ends of them over here. And then he creates a lesion from the SVC to the IVC. That actually isolates a sizable portion of the right atrium. And this isolates, obviously, a sizable portion of the left atrium. He comes back 6 weeks later, and his electrophysiologist, Kernis, touches up. He does whatever might have failed in these lesions. And then he adds lesions, for example, here, if the patient has perimitral flutter. If there's a reentrant circuit around the base of the right atrial appendage, he'd add this lesion. Or if the Coumadin ridge is involved in a reentrant circuit just beneath the left atrial appendage, then he'd put a lesion across there. So what they reported is 88% success rate at 54 months, I believe it is. And this was it was published in the European Journal of Thoracic Surgery. Jean-Luigi Bislari has put these things together, and he's now in Canada. The only problem, this is called the historic Af2 trial, AF trial. The only problem is that nobody else has been able to reproduce these results. But these are the best results reported for hybrid procedures, and they're quite good. In Maastricht and Brussels now, Mark Lemire has changed to a totally left-sided procedure. And this shows the left lateral hybrid ablation that at 42 months, he's out around 70% or so. Bart Van Putte does this procedure from both sides, thoracoscopic procedure both sides, mainly because on the left side, he wants to be able to get the left atrial appendage. His results are also quite good. They call this a TT maze procedure. I call it a TT modified maze procedure. But the results have been about 82% success rate at 1 year. This is the hybrid maze that I described in doing these lesions in a certain way and then coming back and with an obligatory follow-up study and doing a CTI lesion and so on. The maze, the right-sided lesions are altered some. You should never do the full right-sided maze lesions and a CTI lesion because you'll isolate the lower part of the right atrium. This is the popular convergent procedure now. It's done with what's called an EpiSense device, which has a vacuum that sucks the atrium up into this length here. And then these are unipolar RF electrodes. You slip this through a subxiphoid incision, and ablate basically the posterior wall of the left atrium with this EpiSense device. And then the that's what's shown here in blue. The cardiologist comes back, completes the pulmonary vein isolation. And so you've got basically a box lesion that may extend a little bit more broadly than the standard box lesion with a catheter tip. But the procedure works quite well. It's about, if you look at the results on medications or without changing the medications, 2/3 of them are cured at 2 years. This is for long-standing persistent atrial fibrillation. Mark Lemire and Pison and Bart Mason and a group at Maastricht reported this interesting study, which is a meta-analysis of all the hybrid procedures. And these in red are the results reported in the literature for catheter ablation alone. And this is for long-standing persistent atrial fibrillation. The ones in blue are the results reported in the literature for hybrid procedures. So clearly the hybrid procedures are a bit more effective than the catheter ablation alone. So I'm going to stop there. I thank you again for the honor and privilege of speaking to you, and I'll be glad to answer any questions you might have now.
Thank you very much, Dr. Cox, for this excellent presentation. So we'll open the floor now for any question from the audience. I will start with a question. How do you usually manage these patients post-operatively, Dr. Cox? Do you start them on any certain medication? Do you keep the anticoagulation for a certain period of time?
Yeah, that varies a lot from one group to the other because of what you just brought out, the anticoagulation and also prophylaxis. We tried all kinds of prophylaxis on these patients and found they didn't matter much. But I think it's safe to say that most physicians will put the patients on a low-dose amiodarone for a while during the healing period. We've always practiced the protocol that the first 3 months following these operations don't really matter because you'll have so many bizarre arrhythmias and what look like recurrences and so on and so forth. And I always tell my patients, you've got to give me 90 days because you can have almost anything happen in 90 days. Then you almost certainly will have some arrhythmias, but we'll just treat them with medication, as they come up. But after 90 days, we'll stop all medications. And anything that happens after that would be considered a failure. And I think that's the way most people practice it. Some try to prophylax the patients. If a patient has atrial fibrillation post-op, then we'd treat that. In my experience, that almost never occurs. If it does occur, it usually indicates, I think, that you may down the road have a failure. But I don't want to be too squishy with my answers. So I would say that all the patients we would anticoagulate for 6 weeks to 3 months, depending on how much trouble they're having. And certainly for 6 weeks, though, and put them on probably 200 milligrams of amiodarone if they don't have some contraindication to it. And we would stop everything at 3 months.
Okay. What about the left atrium size? Is there any consideration, cut-off point, maybe that's preclude you from doing the procedure?
Not necessarily that would preclude you from doing the procedure. Here's the situation on the size. There is a condition called giant left atrium syndrome that you've probably never seen. I think I saw one. I've seen one in all my career. You can't do anything about that. I mean, these things are giant. But if you're looking at the general spectrum of large left atrium that occur in association with mitral valve disease and left heart failure and things like that. Then the results start dropping when the atrium gets to be above about 6 centimeters. I always use the cutoff of 5.5 centimeters, but not the cutoff to not do the operation. If the atrium is bigger than 5.5 centimeters in diameter on echo, then I would always downsize the atrium. And the way I downsize it, we can get into if you like, but I think that if you have a 6.5 centimeter diameter atrium and all you do is go in and put the lesions in the right spot and they're all perfect and everything, you're going to have a fairly high failure rate. I've said many times that the lesion pattern of the maze procedure works basically every time if you put it on something the size of a grapefruit, or even something the size of a grapefruit. If you put it on something the size of a football, a soccer ball, or basketball, it won't ever work because there's too much distance between the lesions. Same pattern, it just won't work. So you have to downsize the atrium if it gets above about 5.5 centimeters, I think.
Okay.
I might add that's one of the limitations of catheter ablation is that you can't downsize the atrium. And so that makes it difficult.
Do you think these numbers are reproducible for especially like a young surgeon, or you need to have a special fellowship for arrhythmia to have this successful?
Well, I think it would certainly help someone starting out in their practice if they're interested in this type of surgery. And I think you should be interested in it because it can make up a sizable portion of your practice. I think you should spend some time. We don't have any set standards or anything, but I think you should spend some time with a surgeon who's very well versed in this and knows how to do these procedures. It's not as complex as it seems, but you have to see a few and participate in a few. And then like anything else, it sort of clicks for you and you see it in 3 dimensions. And once you see it that way, it's absolutely easy to do. These operations are not hard to do at all unless you don't know what you're doing. And if you don't know what you're doing, then you're in, it's a problem. So yes, I think it would be, if you plan to spend a sizable portion of your practice in this type of surgery, then I think it would be good to spend some time with an experienced surgeon. How much time? I've had people spend from 2 weeks to 2 years, actually 4 years, studying all the nuances of these things. But I think that probably depends on how many operations a person does. If you go to somewhere where they do a lot of maze procedures, for example, then that carries with it the obligation that the electrophysiologists are there and they're involved in it and so on and so forth. And I think, in some places you could probably spend a month there and it'd be enough. I think optimally 3 to 6 months, that would be better. I think optimally it'd be great to spend a year, but that's sometimes hard to do. We do have fellowships that provide funds for people to do this. There's a fellowship, actually it's in my name. It's a Cox Fellowship that the AATS has for people who are interested in spending time with surgeons. And it's well funded. And we've had, I think, about 30 fellows now, 30 or 40 fellows. It's always full. So I'd suggest that if there are people there who would like to spend some time looking at this, that you can go to the AATS and find that fellowship that's actually in my name and pursue it, because there are what it is a list of about 10 or 11, 12 surgeons who are expert in these procedures, who have agreed to accept trainees from abroad for varying periods of time to study under them.
Thank you, Dr. Cox. So anyone from the audience have question?
Mm-hmm.
Dr. Khugir, we have Dr. Khugir as our program director here at King Faisal. Not sure you have any comment for Dr. Cox.
Oh, Dr. Cox, thank you very much for giving us your time. Just something from the past, I was trained with Dr. DeBakey, and I've been with this King Faisal Specialist Hospital for the last 40 years.
Oh
So,
my God.
but it's really nice to hear you, just like always on conferences, and those guys should really realize how fortunate they are to have this 1 hour with you. I really appreciate your offer for their fellowship or for the traveling fellowship, the Cox traveling fellowship offers. So I hope they will take that opportunity. We do have quite a bit of share of those arrhythmias, just like everybody else. And I'm amazed, like everybody else, with the results that you've got and the generations that you have taught. Thank you very much again.
Well, thank you so much for your comments. I really appreciate that. Anybody who trained under Dr. DeBakey, I always listen to what they have to say. So congratulations on your long tenure there. And again, it's been a great honor for me to spend this hour with you.
Thank you.
So
Right. I believe we don't have any more questions. So
okay, great.
I would like again to thank Dr. Cox, and hopefully we'll see you next time physically
Okay.
in Riyadh.
Very good. That would be nice. I would like that. Thank you so much.
Thank you very much for your time.
Bye-bye.
Bye.
So with this, we'll conclude our session for today. Thank you.